Great, let's go ahead and jump in. I'm so excited today. We have two wonderful presenters with us to give a little bit of a talk on Utah's measles response, so some lessons from the front lines of epidemiology and infection prevention. Um, just a few quick disclosure slides, and then we'll go ahead and jump into it. For those who don't know me, my name is Ariana Boschera, and I am a project manager with the Disaster Health Echo team. So very quick overview on Project Echo. It is a case-based virtual learning learning platform, connecting experts and frontline teams. We focus on expanding access to expertise, promoting best practice, and reducing isolation. We're led by Denver Health over in Denver, Colorado, and we're funded by the Robert Wood Johnson Foundation via the Echo Institute. We have biweekly virtual sessions running through January 2026. And we are part of the HHS Region 8, including Colorado, Utah, Montana, North Dakota, South Dakota, and Wyoming. And our overall goal is to strengthen regional preparedness through shared learning and collaboration through sessions like these. So again, just appreciate everybody being here. As I mentioned, we are funded through ASPR. This content of the presentation is a product of the individual presenters and does not represent the official policy of the United States government. And this information is not meant to be a substitute for professional medical advice, diagnose or treatment. With that, I'm very excited to introduce our presenters today. So our first presenter is going to be Amelia Samuelson, the Viral Hepatitis and Vaccine Preventable Disease Epidemiology Manager from the Utah Department of Health and Human Services. She's well, I already mentioned that. She received her Master's of Public Health at Westminster College in 2017, concurrently working as a vaccine preventable disease intern at the Utah Department of Health and Human Services. Following her internship, she was formally hired as the Utah DHHS within Disease Response Evaluation, Assessment, and Monitoring, or the DREAM program, where she still sits. In her free time, Amelia enjoys hiking, skiing, cooking, golfing, and spending time with her husband, Eric, dog, Measles, and kitties, Dexter and Wizzy. Wonderful names. And then our other presenter, who I'm also very excited to have with us today, and her name is Angela Weil. She is the clinical coordinator in the healthcare associated for infections, antimicrobial resistance, also with the Utah Department of Health and Human Services. She has over 20 years of experience in a variety of clinical settings and holds a certification in infection control and is dedicated to preventing healthcare-associated infections for Utah patients. In her spare time, she enjoys reading, hiking, and spending time outdoors with her husband and two sons. So with that, I am going to hand it over to them to present. So thank you all for joining, and thank you both for being here today with us.
Thanks, Ariana, and thanks everyone for having us. Let me just pull up my presentation. Is that working? I think so.
Yes.
Okay, great. So some things we're hoping to accomplish today are to provide a situational update on our outbreak and addressing some of the implications perhaps for your states. We're also going to discuss, kind of how we've been navigating the outbreak response with some challenges and highlights, and then share insights and lessons learned specific to clinical exposures and post-exposure prophylaxis. Whew, pep. In terms of an agenda, I'm going to start with a situational update, hopefully not bore you all too much with some data, and then just give a little bit of kind of tell a story and provide some context to where our outbreak started. And again, highlight those implications and insights that may be impacting your state, and then review some of the challenges and successes that we've been having in our response. Before I get into it, I am curious. I believe there has been measles in all of the states that are on this call, and I'm just curious. I don't have a poll set up, but I don't know, like a little hand raise if any of you have responded to measles in some capacity, either now or previously. Okay, I see a couple, or I see one. Awesome. Okay. Well, hopefully you don't have to deal with too much, but unfortunately, I do somewhat suspect that we will continue to see some measles cases in the foreseeable future. Okay, so what is going on in Utah? Before I do get too far into this, I do want to credit the Arizona Department of Health and the Mojave County Local Health Department, as well as our Southwest Utah Public Health Department. I'm going to speak generally about what's going on in Utah, but really, again, kind of highlight our largest outbreak. But because Arizona is not in Region 8, I know they're not on this call. I'm going to speak a little bit about, the work we've been doing with them, as well as, our outbreak that is really shared with them. But, I'm not going to be providing any data or too much detail on their cases. I don't want to speak for them. And then in general, I'm just going to keep some case details high level for privacy purposes, just given that this is still an active, ongoing outbreak investigation. But yeah, I'm excited to get into it. Okay, so just a little bit of context too to what Utah looks like and how especially our public health structure works. We have 29 counties with 13 local health jurisdictions. We are decentralized, which I think is really something that's important to note. It allows really our local health jurisdictions to somewhat respond autonomously in how they would like to proceed with outbreak response for all infectious disease conditions. I will just note though, Utah does have a governance system and has really been honestly working, I would say, collaboratively throughout this outbreak to try to streamline and centralize messaging and response as much as possible. But it is certainly a challenge in a decentralized state. Okay. So of those 13 local health departments, we have seen cases in 11 of them. And I should mention too, we are early in 2026. I'm speaking to all numbers from our 2025 outbreak as well. Um, but these numbers are primarily driven by the Southwest Utah, Northwest Arizona outbreak. Perhaps some of you have heard about it. At one point, it was one of the largest outbreaks in the country, but South Carolina is competing with us a bit right now. We have started to see, though, in recent times, an increase in cases in our other counties, which I will provide some more detail on as well. But in MMRW years 2025 and 2026, we are reporting out 251 cases. We did start tracking a metric, which is the number of cases that are reported to us in the last 3 weeks. So right now, the number is at 48. We've been monitoring that for a few months, and it has stayed pretty consistent, I would say around 50. So we are definitely kind of just seeing a really steady pattern of cases. I'll show our epi curve here in a minute. I would also note that this is probably a very small representation of the true burden that we're seeing. Hospitalizations, we've seen 23, so that's 9% of our confirmed cases. And then as we are seeing in other jurisdictions, 93% of our cases are unvaccinated or are not able to confirm vaccine. We have seen 7% breakthrough cases, and that is someone with at least one MMR. And then we have had 6 of our cases report pregnancy during their infection. We have been trying to monitor for congenital outcomes, but so far have not, thankfully, had any of those reported. I did also just want to mention we have if you are interested in our dashboard, we have actually a lot of really great data. So feel free to check out our website. Okay. In terms of the epi curve, so our outbreak did start in June 2025. And as you can see, has just continued to sort of progress. We did see a really big spike following the holidays, which was, to be expected. And as I mentioned, this is just Utah cases. I am going to talk again about the combined outbreak, but I am only reporting out on Utah data. And as I said, we do feel pretty confident that this is an underrepresentation of our cases due to hesitancy to seek clinical care and testing. But I'm going to get into that a little bit. Okay, so how did we get here? In June 2025, we did identify our first confirmed case that did result in 4 secondary cases. I'm not going to go too much into detail about that cluster just for sake of time. But this individual didn't report any travel outside of Utah or the county that they lived in and did not report any known or sick contacts. Um, so, but I mean, really, were not able to get kind of any definitive information to link and understand what was going on with this individual and that cluster. And that did somewhat stay to that group. But within a week of identifying that first cluster, another case was identified in an unvaccinated adult, like I said, without a connection to this first cluster. They did, and then this individual reported travel to Southwest Utah and Northwest Arizona in the weeks prior to symptom onset, where they also reported that at least one individual that they were with on the trip, they suspected had measles, but did not seek testing. This case was ultimately hospitalized due to several complications and did recover without issues. And then we were able to identify a secondary case from that individual, kind of being cluster number 2. Um, but something that really stood out to us during this particular small cluster was the report that the family is aware of others in their larger extended family who have been experiencing measles for several months, reporting really that many of them had not been seeking medical care or testing, but this has been going on for a while. And during the investigation of those 2 clusters, we also were notified of 2 residents with a permanent address in Southwest Utah who were diagnosed while visiting family in South Dakota. I don't know if anyone's on from South Dakota, but hello. Um, they these individuals did report a measles exposure in Utah, and also their permanent addresses were in the Southwest district where this other individual had reported having contact with family with measles. These individuals did not provide a lot of details in terms of names, and we weren't really able to make any definitive epi connection there, but certainly raising some flags with us. And sorry, this was kind of that third cluster in South Dakota. Um, okay. And then we did also, in the weeks following, identify 2 additional confirmed cases in Southwest Utah. And we did suspect that they might have been related to these clusters 2 and 3, these 4 outliers, but we really weren't able to confirm. So at this point, we were starting to see a pattern in these case report forms, but really kind of had 3 separate clusters and 2 additional cases. And then in August 2025, I got a call from the Arizona Department of Health regarding a confirmed case in an unvaccinated child from Arizona who attended school in Utah. I am going to, it's important to mention that the area where we're seeing this outbreak is the community lives really on both sides of Utah and Arizona and attends school on both sides as well as works on both sides. So really quickly, we were working very closely with the Arizona Department of Health and our local public health departments. And with school at this point too, so it's August 2025, school was about to start in a week, and that's really why they contacted public health. So within a week of identifying that first case, Utah did confirm our first case on our side of the town in a child that attended the same school and had known contact with this individual. And at this point, Utah and Arizona had identified an additional 6 households that were impacted by these initial cases. And these homes were primarily large, unvaccinated families, which did result in many secondary and tertiary cases and ultimately was the start of our large outbreak. That's when we really started working with Northwest Arizona, and our local public health departments, basically one time, weekly and regular communications. I'm going to kind of circle back to highlighting some of that in a bit. Okay. So one thing too, I did just want to point out, at this point we have all these households. We're starting to see, kids going to school. There was a lot of pushback on those kids being excluded from school, and ultimately did, most of them did go to school. But I did just want to highlight, the vaccination coverage rates in this area are very low. Washington County, which is primarily where we were seeing our side of the cases, has about an 80% vaccination rate, which in some ways is higher actually than I anticipated. And Mojave County, Arizona is really similar. But, you know, this is similar to the vaccination rate, I believe, in Gaines County, Texas. So from here, it did unfortunately really take off. So I just want to show kind of that image of where we were concerned about spread and where we are definitely continuing to see spread. Okay. So as I mentioned, the outbreak has generally straddled this what is known as Hilldale, Utah and Colorado City, Utah, commonly called the Short Creek area. And in November of 2025, Utah started to see cases really outside of this small area and into other areas of the region of the state as well as northern Utah. So given this kind of broad community spread, we did put together a very simple like outbreak definition, just to try to kind of make sure that we're linking all of the appropriate cases together. It was getting a little bit blurred with the growing outbreak. And really, in simple terms, this is people who live in or visited the area, and we're counting that whole region of the state at this point, given broad community spread, or have had contact with a confirmed probable or suspect case who visited or lived in that area. I'm not going to extend too long on it, but I will just note that I know in January 2026, CSTE published an optional operational guidance expanding kind of the use of epi-linkage criteria for confirmed cases when community transmission is occurring. We are not following that at this time because our outbreak started before this document was developed. And so we're kind of sticking to our case definition and how we're linking cases really based on epi-link and lab confirmation. Just a plug too, as I kind of get going on this. If you suspect a case in your state might be linked to our outbreak, please let me know. We'd love to connect, and our public health lab is doing sequencing on these samples as well, and it's provided some really good insight to connections in our part of the country. Okay, so what does this mean for you guys? Maybe some of you know this, but in August, or since August, really, we've been working very closely with Arizona, both state and local, to respond to this outbreak. And I am going to provide a little bit of insight to this community, just given possible connections to your states. But I do ask, that you be sensitive with this information. I think it's important to bring up in an effort to help really people understand kind of the historical context of this community and why they are being so impacted by measles. But what we have seen, in this area, specifically in Short Creek, is a community that was historically isolated from mainstream society. They experienced significant trauma, both from the government and their own kind of internal leaders. And really, what we've learned is a lot of the root of their hesitancy and trust working with public health, the government, and healthcare, engaging in healthcare. There's a lot of shame, fear, and stigma, I think, rooted in this. This community most often lives in large multifamily households, which are primarily unvaccinated. And as I mentioned, they don't typically seek routine or health care. And I think there's a lot of misinformation around vaccine. The other thing that's interesting about this community is they're highly mobile. During some of our investigations, we've definitely discovered a lot of work-related travel. Often, I would say by car, not as much by plane, but definitely seeing some patterns with construction work and people from this part of Utah basically going to work jobs in other regions of the US or other regions or in our region and other states within the US, sorry. Um, and the other thing too is we found, and I think this is why we're not perhaps getting as much of a capture of our cases. They know what's going on, and they recognize measles. I mean, they actually came to us and said, this has been going on for a while. We're just now kind of looping you in because we need some support. And we do often hear of of the families basically staying home because they've identified someone that likely has measles in the house, and they seek care if it is urgent and needed. And I would say have been really great generally about calling ahead prior to care. Um, I'm generalizing, but this is just kind of the patterns that we've noticed. And I do want to mention too that, in speaking with them, they have told us, that they have families and communities in Region 8. They've particularly identified, Utah, Arizona, Colorado, North Dakota, and South Dakota, but, you know, connections we are aware of in New Mexico, Nevada, Montana, Idaho, Wyoming, Missouri, and Texas. I do want to mention too that we did a listening session with the community down there a couple weeks ago, and they were very, I would say, the positively received to have someone go in and asking them, what they cared about in their community and what the priorities were. So anyway, I think when we get to discussion, we can probably talk a little bit more about this. The other thing I did just want to put a plug in for, I've actually been facilitating an informal meeting with EPIs from other states, and I think there's a rep from all of your states on this call. I've been doing it now once monthly on Fridays, and it's really just a space for us to kind of get together and talk about perhaps relatedness and even just sharing insights or resources. So if that is something you're interested in, please let me know. Because I do think that this is not just a Utah, Arizona, I mean, it's a US issue, but the community that we're really seeing a lot of cases come from are not just living in Utah and Arizona is kind of my point here. And I think, approaching the subject with sensitivity is really important, and that's kind of my key message here. Okay. Off of that soapbox, I figured I would just share too some general information on how we've been navigating the outbreak, one in this complex community, but also just the general shift in the public's perception of measles mitigation and our limited public health capacity. We are certainly still figuring stuff out and navigating challenges, but I did just want to give some information on what we've been doing. Okay. I've highlighted a lot this cross-border collaboration with Arizona. Honestly, I cannot reiterate enough like how great it has been. We've had really routine communications, check-ins. One thing that we also do have that I think has been very helpful is a shared line list of our cases within our outbreak. It's helped us identify households and epi linkages, but also these individuals, as I mentioned, live kind of in between both jurisdictions. So it just kind of allows us to make sure we're not also duplicating work. So that's something I do recommend, of course, if you have any sort of, kind of cross-jurisdictional incidences to hopefully you can have a good connection with that other local and state health department. A few other things that I think have been really beneficial. Both our state labs do in-house measles PCR testing and have provided supplies they're actually available to any of our clinics, but specific to our community in Utah and Arizona, we provided them free supplies and I believe a daily courier to pick up samples to go to the health lab every day. So we've had really quick turnaround. And honestly, the most important thing that has been helpful is that Mojave County, Arizona has a nurse on their staff who grew up in this community and is a very great advocate for both sides of the issue and kind of the complexities, and again helping us kind of understand and be sensitive to the situation. And really, we're plugging most of our messaging and communications through her. So that's been really great. And as I mentioned, we did conduct that listening session. It was general, not specific to measles, but I think showing up and asking people what their needs are was an olive branch into that community. And honestly, our goal was to sort of, this isn't just measles, was to kind of create more of a relationship for other things that might be coming up. Um, okay, so this was an issue, perhaps schools and extracurricular activities. I did mention that we didn't do any specific mitigation in the schools, but Southwest Utah and Northwest Arizona really did take a pretty hands-off approach. And again, it was reception from the community. Arizona actually, I would say, went in a little bit stronger with their schools, and it damaged the relationship a bit. So that's been across the state in a fine line to navigate. Um, but the other thing that came up at this point, there was so much widespread community transmission that keeping kids out of school wasn't necessarily reducing their exposures. I wouldn't say that that is going to be in everyone's district, but that was something that we did kind of learn, at least in that community. Um, Okay. And then the other thing that we're still dealing with is a lot of the schools and extracurricular activities really want to wait for a confirmation test before they're acting on anything. And I do understand, assessing the situation and not maybe moving and causing fear on everything, but it has delayed, I would say, response a bit. And I think I've heard from other states that they're having similar experiences with their schools. Um, and then, as I mentioned, we're decentralized. So each local health department is handling their schools and their extracurricular activities differently. I would say generally it's all pretty similar, but at the end of the day, they do have the authority to kind of work directly and make individual decisions, which has its pros and cons. I do want to highlight that it's not required, but our state did come up with a risk-based approach and matrix for the schools to, kind of maybe not perhaps exclude everyone, but at least gives a bit of an ability to meet people where they are and not just say it's exclusion or nothing. Um, and then the last thing I'll kind of go into before I hand it over to Angela is we've really been assessing our approaches, just given the steady caseload. We really thought like we'd be out of this by now, but it seems like as it's burning out in one community, it's just continuing to impact other areas and finding kind of all these areas where there's lower vaccination rates, unfortunately. But um, so we actually started off really early on, and I have a table I'll show you quickly on the next slide, but basically classifying our PUI as a person under investigation. When we get a call about a suspect case, classifying them as low, medium, or high for measles, and really focusing again on those high and medium suspect. And on some of our jurisdictions at this point are only have the capacity to follow up on confirmed cases. But I think tiering that and to kind of save your capacity and not necessarily responding to low suspect cases. I will also say the active monitoring that we're doing is pretty limited. That is jurisdiction specific, but most of them are not doing, I would say, full active monitoring the way we would imagine it in our guidance documents. Definitely more of they're doing it in households and really like high risk contacts, and more so checking in every couple days, and just having that open communication. And then in terms of our case investigations, I mean, early on, we found with our main outbreak group, they were not going to give us any information on names or family. And that's okay. We have accepted that. Really, we're focusing on public exposure locations and, you know, messaging that it's about mitigating the risk for others and making them aware. And that has been pretty well received. I really would not push people on providing personal information at this point if they're not willing to give it. And then the last thing that we're doing, which is actually I would say a bit of a transition right now. I put delegating contact tracing notifications. We have a lot of exposures happening, and us and the locals are actually often working with whether it's a healthcare partner or a school or an event, working with or a business, I guess, working with that specific entity and helping them draft the message and actually having them send it out. In fact, I did one this morning. Um, and Angela's going to talk a little bit about that from a healthcare facility perspective. It's has its pros and cons. But we are trying to steer it so that we're providing templates and messaging and making sure that that public health information is getting out there. I would say in a lot of situations, it's received better getting that from the business or the school or the event directly instead of public health. But it also limits our control and the information we're getting back. But in terms of workload, it's been helpful. Okay, I'm not going to go through this, but this is our classification matrix. I would say we developed this I think I developed this before we had cases actually, or very early on. I would say a few have slipped through the cracks with this, but it's been pretty sound, and I'm happy to kind of share it more broadly. We have actually several versions of this. This is kind of the simplified one. And then again, I'm not going to go through this, but when we classify them as like low, medium, or high, our local health departments in particular really asked for some forgiveness on not maybe doing a full workup on a low suspect case. And so I think this was very helpful for our local health departments in kind of managing their response and not initiating contact tracing and PEP on a low suspect case, as I mentioned. So, okay, I'm going to pause and I'm going to hand it off to Angela to just talk about responding to exposures in healthcare settings. And Angela, I'm happy to drive. Just tell me when you want me to switch. I'm just going to mute myself here.
Thanks so much, Amelia. I'm Angela Weil, and I wanted to we've had tons and tons of exposures that involve healthcare settings because when somebody's sick, that's usually where they tend to go. So what I have found is that there's a lot of resources from the CDC. Your state and local health department may also have some resources available for, steps to take if you're investigating an exposure. But what often is not included in those materials is that these situations can get messy and they do require some critical thinking and some prioritization. So that's really the piece that I wanted to focus on is the information that's a little bit harder to find. And for those of you that have not had a chance to kind of think through some of these situations, I put together a pretty typical scenario of things that we have had to deal with and how we've sort of managed it. And I would really like this to be interactive. So we're going to stop at some point and I'll just invite all of you to maybe just kind of put what you think in the chat, put thoughts, questions, or, what you would do in this situation. So let's go ahead. All right, so to start us off, we've got a 19-year-old male coming to the emergency room with fever, cough, malaise. He's got red, watery eyes, and his symptoms began 3 days ago, are getting worse. He does not have a rash, but he does say he was exposed to measles at a family gathering 2 weeks ago. He is not vaccinated. So, first and foremost, how concerned are we that this might be measles? Anyone feel brave enough to put their opinion in the chat? Okay, yeah. Concern. Okay, go ahead, Amelia. All right. So, one of the first things that we want to look at is, does this fit the timeline? So, in this case, yes. And those of you saying that I would be very concerned are correct. So, he reports an exposure. 11 days later, his symptoms started. That's pretty typical of measles. Also typical, he's had flu-like symptoms for the past 3 days. That fits very neatly with the prodrome period that we see for measles. And, the fact that he's unvaccinated, of course, adds a layer of concern. So in this case, I would be very concerned. Now, if we had the same patient maybe coming in and saying I was exposed to measles, and then 3 days later, I woke up with a head to toe rash, and then the following day had a fever, we wouldn't have no concern, but it definitely sounds a lot less like measles based on the timeline and the presentation of symptoms. So, all right, so let's go to the next one. So in this case, the doctor is concerned about measles and they do order a measles PCR test. They tell that patient to stay home, stay away from other people while they're waiting for those test results. What are some other things about testing that we would want to consider specific to this person? Anybody have any thoughts? No right or wrong question or answers here. Strep or other IDs? Yeah, that's a good point. So let's move forward. There's a couple things to think about. So first and foremost, when it comes to testing, the test is most reliable between the first and the third day of rash. You can test up to 10 days after the rash, but the 1 to 3 days of rash onset are the most reliable days to test. So this patient doesn't have a rash. And so we need to consider that even if he does have measles, there may be a false negative because it's just not time yet. Also, as put in the chat, symptoms are consistent with measles, but it's also consistent with things like flu, with COVID, with other respiratory illnesses. So testing for those things and not just getting tunnel vision and focusing on one thing would probably be a good idea. And then a final thing is that Amelia alluded to this, but oftentimes if we wait for test results, that really can impair our ability to act. And especially when we're talking about post-exposure prophylaxis, that window may be over by the time that we have results available. So next slide. So the hospital infection preventionist here reaches out to her local health department to discuss this case and decide what they want to do. And in this case, the state does, in order to actually confirm a case like we do in Utah, they do require either a positive test or they need to be able to link it to a known confirmed case. This patient reports an exposure, but he did not want to provide the names of the people that he had contact with, so it can't be officially confirmed. However, the local health department also has heard some rumors of other confirmed cases that link back to a family event with similar deep time frame that appear to match what this patient has reported. So they do feel like it's highly, highly suspect. Next slide. All right, so given the concerns about this, they decide not to wait for testing and they want to start moving forward with the investigation. At this point in time, the infection preventionist really doesn't know anything more than they've just had a suspect case. So what are the first things that they would want to start looking at in order to determine their next step? Yeah, reach out to public health. And yeah, if they hadn't done that, they definitely would want to. healthcare exposures. Go ahead, Amelia, and let's. So the first thing is you need to get a good idea of what actually occurred. So if you have a situation where, sometimes we have situations where the person calls ahead, they came in wearing a mask, they were immediately taken back to a room. And that's the kind of situation that we like because the exposure risk to others is very, very minimal. Unfortunately, that isn't what happened here. This patient came to the emergency room when they were very busy. They waited in the waiting room for about 90 minutes, was not wearing a mask. And when they did take him back to a room, they took him to a standard room. It wasn't until the nurse started assessing him that the alarm bells kind of went off for maybe this could be measles. And at that point, they took him to a negative pressure room from there. So now that they were concerned about measles, when it was time for him to leave the emergency room, they did have the patient wear a mask and they had someone escort him through an unused side exit to minimize any exposure. Next slide. All right. So another thing that the infection preventionist does is she talks to their hospital maintenance about air handling in the emergency room. Most outpatient clinics are not going to have monitored air handling, but a lot of acute care hospitals do. So she learns that their emergency room and their waiting room have at least 8 air changes per hour. And based on this, how is she going to determine what the exposure window is from this setting? And let's just go to the next slide because I don't expect anyone to have this memorized. So according to the CDC's guidance, the way you calculate this exposure window is you count any amount of time that an infectious person that was in a shared airspace with other people, or for that 2 hours after the infectious person left, because that's how long measles can stay active in the air. However, if you know the air changes per hour and if you have a monitored air handling environment, you can actually look at the time for 99.9% clearance efficiency. And in this case, because they have 8 air changes per hour, really after 52 minutes, they know that they've gotten rid of almost all of the contaminants in the air. So we know a couple of things about this case. First of all, this patient was eventually moved into a negative pressure room. A negative pressure room does not vent to other areas in the emergency room, so there's no shared airspace. So once they were moved into that room, there was no shared airspace. And instead of 2 hours after that point, they can reduce that window to 52 minutes after that time that the patient moved into that negative pressure room as their exposure window. Does anybody have any questions about that? That can be a little bit confusing when you're not used to working with air handling systems and that sort of working that up. All right, let's go to the next slide. All right. So given that time frame, sometimes they can really try to look into specific areas and try to gauge who was in which specific area at which time. A lot of times after the fact, that can be really difficult. So what a lot of facilities do from a practical standpoint is they look at what time the person walked in the door and checked in at the front desk to that time period after they left or went into somewhere without shared airspace. And during that time frame, they identified 43 patients and 25 healthcare workers that were exposed in the emergency room. They do not collect information on visitors or people who might have come with that patient to the emergency room. So they are not able to contact trace those contacts, but they've still got a lot of people that they've identified were exposed And the next thing to think about is that's a lot of people. How do we prioritize and what do we do next? And we can just go to the next slide. And what we really want to emphasize, if we can, is post-exposure prophylaxis. If you can prevent somebody from getting sick, that's obviously a much better option than simply notifying them that they might get sick. So if we can give PEP, we like to make sure that we prioritize those people where we can actually do something to mitigate the harm. So there are two types of post-exposure prophylaxis. The first one is an MMR vaccine. And MMR is not usually given to babies until they're 12 months of age, but it can be given to anyone older than 6 months if we are aware of a specific risk. So any babies 12 months or under, a lot of time, or if they're under 12 months, you can pretty well safely assume that they're going to need some kind of post-exposure prophylaxis. And if you're within that 72 hours, 6 to 12 months old, you can give them a dose of MMR and it will give them some protection. They still will need to complete their full series, so it's an extra dose. They'll need the 2 doses still later on, but it does give them some immunity to keep them from getting sick. And of course, anybody older than a year can also get an MMR. There is an added layer of trying to determine who is and who is not vaccinated. So that involves things like looking at their medical records, and also if you have a state database that you can search for vaccines, that can help get some of that information, but it's a little less straightforward. The other type of post-exposure prophylaxis is immunoglobulin, or IG for short, and you have up to 6 days to give that, but there's a much narrower criteria of who's able to get it. So babies that are less than 6 months old, that's the only form of PEP that they can get. If they're between 6 to 12 months old, it's generally better to just give the MMR if that's still an option. But if you're outside of that 72-hour window, then this is still an option for them. Another group is if you have pregnant women that are unvaccinated, you cannot give an MMR vaccine during pregnancy, and they are very high risk. So immunoglobulin is the option here. And then also people who are severely immunocompromised. This would be people such as those who have had whole organ transplants, people who are on certain types of chemotherapy. And this is regardless of whether or not they have previously been vaccinated, because we just can't trust that their immune system is going to be able to mount an effective response on its own. So those people also are eligible to get PEP within that 6 days. Next slide. There are some things to understand about immunoglobulin that are really important to think about. So first of all, and I have bolded this, do you have a plan to administer or refer patients for IG when it's needed? And unlike MMR, where it's pretty easy to find a clinic or a pharmacy or somewhere where they can get this, immunoglobulin is far less widely available. There are a lot of people, there are a lot of providers that will struggle to give it, especially IV requires a lot of advanced coordination. And so pretty much just sending somebody out to follow up with their pediatrician or an outpatient clinic, or even sending them to an emergency room, is pretty unlikely to result in them being able to actually get the medicine unless you've actually coordinated this in advance with the facility. And it does take some time to get all of the pieces in place. So as early on as you can, I would recommend starting to work on a plan to make sure that your patients are going to be able to get this. So there are 2 ways that it can be administered. The first is intramuscularly. This is primarily for small babies. So The package insert technically allows for doses up to 15 milliliters. However, from a logistical standpoint, this is extremely challenging. Even the dose is weight based, and even when you have to give a dose more than 4 or 5 milliliters to a small baby, that's extremely challenging. The dose has to be divided between 2 and 4 injections. And, once you get past 4 milliliters, even if you're giving it in 4 different sites, you have to kind of stretch what you are, what's typically recommended for injection volumes to give. And that's only around between 17 and 20 pounds that we start to run into those problems. So for larger infants, that can be a pretty big challenge. With IV administration, there are no weight or age restrictions, but it is expensive. We've been told it can cost up to $30,000 for patients. Their insurance, unless they're very high risk, so unless they fit into the groups that we discussed, their insurance probably is not going to pay for it. And it can be extremely challenging to find an appropriate place to refer them to. So just some things to keep in mind. I'm just curious, has anyone had any experiences with having to try to give or coordinate IG for patients who are exposed? All right, not seeing any hands. I will tell you, it is quite the experience, and we've had a lot of lessons learned. I can't just emphasize enough to just start trying to coordinate that as soon as you know that there may be any potential need. Next slide. So now we run into a snag. This patient's test result is back, and it was negative for measles. But today he has also developed a rash, and he went back into his local health department where they collected another test. They sent it off to their lab, but we will not have the results for that in a couple of days, and we only have a day and a half to still give MMR for PEP. So what are we going to do with that contact list that we've compiled? All right, next slide. In this case, you really want to weigh the risks versus the benefits. So in this case, the hospital calls the local health department, and they kind of collaborate, and they think first of all about MMR because you only have 72 hours. And they think about, what are the risks of if we give MMR and this is negative? Well, really what happens is that you vaccinated somebody during a measles outbreak. The MMR is pretty safe. It's pretty low cost. And really the only thing that you've lost in that situation is that it does take some manpower to actually call people, because you do have to, if you're trying to give post-exposure prophylaxis, you really need to directly contact those people. Sending out any kind of electronic notifications, it's probably not going to be realistic for them to get it within the time frame. So there is some manpower involved, and you may also maybe cause some unnecessary fear and panic, especially when you're talking about infants. People tend to get pretty worried if they feel that their baby's been exposed. But they decide that overall that proceeding with giving MMR to the people that are eligible makes sense before that window is over. So they start contacting those people. They also do the same thing with their healthcare workers. They have their occupational health department look into healthcare worker immunity, and if they don't have records, then they offer MMR to any of the healthcare workers that have been exposed. They decide with IG to wait on giving it or notifying the patient, but they do start to look at who has the risk factors that would qualify them. And if it is needed, where are we going to send these people so that they can get it? So they do start thinking about those things. And then if the test is positive, then they will go ahead and start contacting the patients with IgG. Again, individual outreach is the way to go with that. And for everybody else, so for the patients where they've been able to verify that they have at least some immunity, they will send out electronic chart notifications instead of trying to call dozens and dozens of people individually. They're also going to provide the local health department with a line list of exposure contacts so that if any of them do later on wind up having symptoms, that the local health department can confirm that exposure. And because they aren't able to contact trace all of the visitors and the people that came with patients to the emergency room, they do decide to list the exposure location and time frame on their state measles webpage. So I go ahead to the next slide. And in this case, the repeat test was positive. They were able to successfully notify contacts, get PEP, and arrange it within the appropriate windows. So thanks very much. And I'll just hand it over to Amelia for our last couple of minutes.
Thanks, Angela. I know we're butted up on time. I made this slide that was kind of a summary overview, but yeah, I kind of want to open it up too and just see if any of you have questions before I keep going, because I know we only have a couple minutes. Okay. I would say, again, if you get anything out of this in summary, which my joke, I thought this was funny. I put too long, didn't read. Rethink your approach. Measles virus has not changed, but the behaviors and people's perceptions of vaccines and public health have definitely changed. I think it's important to meet people where they are, ask questions and listen. I would say at this point, you know, building back that trust is at least a goal that I have. Working in vaccine preventable diseases, I don't think that this is a measles only issue. It's just what's happening right now. And then, oops, I'm sorry. Evaluate your priorities and your long-term sustainability, especially if you do start to get a large outbreak. And really, I mean, the importance of partnerships with our clinical partners and our healthcare systems is, I mean, I think Angela and I I started joining meetings with the healthcare facilities at least a year ago to try to talk about IG coordination and all this stuff. And honestly, until it happens, it was a lot of talk, but it has been very valuable to have routine communication with our healthcare partners. And honestly, we have open doors to when we need support from each other. So I do just kind of want to reiterate, if you are able to kind of continue fostering those relationships with your clinical and your public health partners, it's really important. I'm going to skip my little questions in here. Here's a last slide on some feedback. I'm sorry we kind of butted up to the end, but my next slide has our info. Yeah, curious if there's any other questions. I'm happy to kind of linger here for a second too. And I think here's our info, maybe. Might have missed it. Anyway, sorry, I might have skipped that slide, but Ariana can send it out if you need to contact us later. Thank you.
Both so much. Really appreciate it. I know I learned a lot. And I really hope you have a great weekend, and thanks again for being here.
Thank you.
Have a good day, everyone. Thank you.